Hello, my name is Irene Sue. I am a reproductive endocrinologist currently at the University of California, San Diego. And today this micro video focuses on some of the challenges in using antimullerian hormone, or AMH, as a diagnostic tool. So the premise of using AMH has to be based on what makes a good diagnostic test. Well, the data should be applicable to patients in your practice, and that the results you look at will change your management, your practice. In this schematic below, really a good diagnostic test, for example AMHs, which we're speaking about today, should be clinically relevant, meaning that it should be associated with outcomes that are relevant to our patients, whether it is a live birth, whether it is becoming pregnant, or whether it is predicting time to menopause. This should be easy to interpret, sensitive and specific, and objective and reproducible. And these are some of the topics that we will touch on today in this video. So is AMH clinically relevant to predicting pregnancy? Well, one early study showed a positive association between AMH and day-specific fecundability in about 100 couples who were attempting pregnancy. This is a study that was reported in the Green Journal in 2011. In these 100 couples, 64% conceived within 6 months without assistance, and an AMH level of less than 0.7 nanograms per milliliter was associated with a lower hazard of pregnancy. But since then, there has been a preponderance of negative studies to follow, including one by Steiner et al., hot off the press in JAMA in 2017, where this cut point of AMH less than 0.7 nanograms per milliliter was not associated with time to pregnancy in couples without a history of infertility. One other study that I want to show you is looking at whether AMH levels in folks who have had 1 or 2 prior losses improves the next pregnancy outcome. This graph is a survival graph, and it's a secondary analysis of the EAGER trial. In this trial, aspirin was tested to see whether women with 1 to 2 prior losses would improve their next pregnancy outcome. These women were assessed for AMH levels prior to conception and divided, as you can see here, low being less than 1 nanogram per milliliter, normal 1 to 3, and high greater than 3.5 nanograms per milliliter. And in the graph, you can see that the proportion becoming pregnant over the number of menstrual cycles really aligned altogether for these 1,200 couples, indicating that AMH, at least at these cut points, are not associated with time to pregnancy in couples without infertility. I next want to give an example of whether a single AMH level is easy to interpret. Is it sensitive and specific? At this point, multiple studies have shown that AMH in late reproductive age women is associated with the timing of menopause. The Cardiac Women Study, which I'll show you, is an ongoing cohort study designed to look at the association between androgens, polycystic ovaries, and associated clinical features with atherosclerosis. And these data are a secondary analysis looking at AMH and time to menopause. So exposure in this secondary analysis was AMH and ovarian reserve at around year 15 of follow-up of this cohort, when the women were on average about 43 years old, and the outcome was whether they achieved menopause within 5 years of measurement. In models of whether AMH, antral follicle count, or FSH improved the prediction of age at menopause, AMH and age did better than AMH alone. Adding antral follicle count or FSH did not improve upon the base model of AMH and age alone. Moreover, women who have an AMH of over 2 nanograms per milliliter did not experience menopause within 5 years. However, how easy is this to interpret for clinical utility? So these are the data from this study, where I've added a purple point to depict a woman who is 44 years old and who tests for an AMH level of 0.3, as you can see on this graph. Well, the probability that she is menopausal by the time that she is 49 years old is 25%, but even if her AMH were undetectable, the probability is no higher than 50%. So AMH in the prediction of menopause still needs some clinical precision for clinical utility. There are 2 considerations in using AMH as a diagnostic test for age at menopause. First, the research literature really has to move beyond association to cut points that optimize test characteristics like positive or negative predictive value, and this will help render these measurements more clinically useful and easier to interpret. Therefore, AMH in the prediction of menopause still needs precision for clinical utility. I wanted to provide 2 examples to demonstrate issues with reproducibility of AMH. The first looks at the timing of puberty. So this is a study from the Journal of Pediatric Endocrinology and Metabolism, where a cohort of 137 girls were followed from about age 5 yearly until age 14. And you can see AMH depicted in this first figure in the triangle plot, with an overall trend to gently increasing, a modest peak at 9 to 10 years old, and a slight decrease from 11 to 13 years old, followed by another rise at 14 years. The intra-individual variability was 45% for these girls. So while these data help to ask questions about follicular recruitment prior to the onset of puberty, but still begs a question of clinical utility if you only have one blood draw. The second example is of a small cohort of young adult cancer survivors from cancer treatment prospectively. The green depicts the timing of AMH levels prior to cancer treatment, and in black, the follow-up period. This cohort was split into those individuals whose AMH levels were less than 2 nanograms per milliliter prior to treatment, and this is the purple flatter line, and those whose AMH levels were greater than 2 nanograms per milliliter at cancer diagnosis, and that's the blue line. This graph is meant to demonstrate that AMH levels in cancer survivors are not stable and that over the time of survivorship they can fluctuate significantly. Therefore, there's significant intra-individual variability in physiologic conditions like the onset of puberty and in pathophysiologic conditions like cancer treatment exposure. We'll see in our literature that most older studies have concluded that AMH levels are stable through a menstrual cycle and have very small sample size limiting power. Moreover, their statistical approaches may have biased the association toward the null by not transforming AMH levels, which are not normally distributed, and not accounting for correlation in the same person, both increasing the noise of prior studies. These are data from the Biocycle Study, which took 259 women, on average age 27, who underwent multiple blood draws over 2 cycles. The figure depicted here looks at the variability, and that variability really increases with higher starting AMH levels in younger age. The mean of the maximum observed change in serum AMH levels overall was 1.3 nanograms per milliliter over the course of a menstrual cycle. When you look at the original paper, you'll see that AMH varies, but less than E2 and P4. However, the higher your AMH level, the higher the variability. In this slide, we ask the question of whether AMH level is reproducible. So as you know, AMH is produced as a 70 kilodalton precursor with a 55 kilodalton pro region and a 12.5 kilodalton mature region. AMH hangs out in the circulation as homodimers. The mature region has biologic activity, but requires a pro region for full activity. Among the currently available assays that you see in this table, that antibody pair varies among them. In addition, automation versus manual measurement introduces the possibility of technical error. Consequently, as you'll see in the next slide, one can't simply convert the results of one assay to an equivalent measure from another assay. A second challenge to the AMH assay has been observations that you can see significant variability of up to 20 to 70% difference in the same samples, and this occurred using the Gen 2 assay. This decrease in reliability was attributable to interference from complement. Hence, independent studies on these assays as they become available to demonstrate that they are reliable is really key prior to clinical application. This is a slide asking, can AMH from one assay be converted to an equivalent level in another assay? The brief answer is no. The two figures that I will show you compare AMH levels measured via the Gen 2 assay with the same samples measured using the ultrasensitive AMH assay in 90 breast cancer patients at the time of diagnosis prior to breast cancer treatment. So we often see in these types of studies where AMH levels from more than one assay are trying to be combined, that the measurements are always going to be highly correlated. So in this example, the correlation coefficient is 0.91, but that correlation coefficient really doesn't tell the whole story. A linear regression equation, which I've shown you here, describes the relationship of untransformed AMH levels between the pair of assays. These types of equations have been used to combine measurements in research studies that over time have used more than one assay. In the left figure, this yellow line really depicts if you had a one-to-one correlation. This is a passing Bablock plot which depicts a linear regression line in 95% confidence interval relative to that slope of 1. And this plot shows you that the Gen 2 AMH levels were consistently lower than that of the ultrasensitive assay, but the higher you go, the more deviation. This figure on the right is a Bland-Altman plot, which depicts the difference in AMH levels relative to the mean of the two assays to help determine systematic bias and whether it's uniform across a range of results. So correlative to the figure on the left, the BA plot on the right shows you that as mean AMH levels increase, the difference between the two values get even larger. Together, this and other comparison of assay studies show that AMH levels from one assay are not generalizable to another assay. Research-wise, this means that investigators cannot simply use a regression equation to convert values. Clinically, this means that the AMH level measured in your clinical lab that uses one assay may not mean the same as the results that you see of a published study where another assay was used. So, coming back to the original framework, really what makes a good diagnostic test? We started by saying that data are applicable to patients in your practice, that these results will change your practice. And I hope that we showed some examples of where in certain scenarios AMH tests are not yet clinically relevant, not always easy to interpret, especially in the setting of variability in the same person. There is a lack of validated cut points that are sensitive and specific for the outcomes that we care about, and they're not always objective or reproducible. AMH measurement, I think, is here to stay, and it really has roles in predicting ovarian response in ART, and some promising roles in understanding physiology and pathophysiology of ovarian function. But reproductive endocrinologists need to be aware of the limitations of these measurements and to follow the data closely to figure out whether and in what settings they feel that AMH as a diagnostic test would change their clinical management. In conclusion, there are several limitations of AMH as a diagnostic tool. AMH is poor at predicting clinically relevant pregnancy outcomes, including pregnancy, pregnancy loss, and live births, and unassisted pregnancy attempts. We see significant intra-individual and inter-assay variability in AMH levels that limit clinical utility. This argues for awareness that one AMH measurement often doesn't cut it, and it's a wait to see on whether multiple measures will perform better. AMH measurement is here to stay, and I think has roles in predicting ovarian response in ART, and promising roles in understanding physiology and the pathophysiology of ovarian function. But reproductive endocrinologists need to be aware of the limitations of these measurements and follow the data closely to figure out whether and in what settings they feel AMH as a diagnostic test would change their clinical management. Thank you.